If you have a water pipe and and you're creating an artificial stenosis by pressing with your thumb, the water that's coming out is still sufficient enough to irrigate the small patch of grass. But if you want to use the same water pipe and you have a stenosis created at the end with your thumb, the water coming out is not sufficient enough to irrigate this big grass field, right? So FFR takes into account in a similar way the amount of myocardium being supplied across the stenosis. If you have a huge myocardium being supplied, the FFR might turn out to be significant even for a moderate disease. So what I mean to say is, if you have, as an example, LED lesion which is 50 to 60% angiographically stenosed, and it's only supplying the LED territory, the FFR might turn out to be non-significant. But if the same LED was now cross-filling a huge dominant right coronary artery, so now the vascular bed has really increased. The vascular territory being supplied is not only the LED territory, it's also the RCA territory. And you have a mid-LED moderate disease, that's the blood is going across that moderate disease. Now if you want to do FFR of that moderate disease in LED, now it might turn out to be significant because the vascular bed ahead has LED plus RCA territory being supplied across. The same thing is being depicted here in this figure. If you look at this, this has a 50% stenosis. This is the myocardium being supplied, it's not cross-filling anything, so FFR is non-significant, it's 0.85. But it's the same stenosis here, the same coronary, but the difference in the diagram now is that this coronary is now also giving collaterals to another vascular bed. So the myocardium being supplied has now really increased, and the FFR now for this same 50% stenosis is 0.73. FFR takes into account the amount of myocardium being supplied. This is very important to remember. Now this is a right coronary artery subtotal occlusion, and this LED had a moderate disease in the middle, and when we did an FFR of this moderate mid-LED lesion, the FFR came out to be 0.73, which was significant because this LED was also cross-filling this right coronary artery. Now after the RCA was recanalized, the mid-LED FFR was repeated, and now that FFR came out to be 0.82. This is exactly what I was explaining. The vascular bed of LED had therefore increased, and hence FFR became significant. This was because it was cross-filling RCA as well. Otherwise, its own FFR was actually non-significant once the RCA was stented, and then the FFR was repeated in LED. Now, the same theory applies if the vascular bed is small. Now this is a circumflex which is non-dominant, and there is a angiographically critical stenosis at the ostium. So when the FFR was done for this circumflex, this came out to be non-significant. How could that be non-significant? Because the vascular bed that it was supplying was small. So FFR is the only mean of gaining a per segment functional assessment of the coronary tree. Stress ECG gives you per patient analysis, the thallium scan gives you per vessel analysis, but FFR can give you per segment analysis of the coronary. So post PCI recommendation, FFR must reach 0.90 or more after balloon angioplasty. Post stenting it should be 0.96 or more, except for if there is residual or diffuse disease. If the post-PCI FFR is between 0.75 to 0.90, there would be ischemic relief, but there is high restenosis rate. And if the post-PCI FFR is less than 0.75, there is some significant lesion that is being missed. Now, I don't have the case with me, but I can tell you that this is a diagrammatic representation of that case, where patient was very symptomatic and the only disease we could find was an intermediate appearing diagonal disease in a good size diagonal. So since it was intermediate, we wanted to be sure if the FFR was significant. We did an FFR in the diagonal, it came out to be 0.50, which was surprising. With an intermediate disease in the diagonal, FFR was highly significant. Anyways, we stented this diagonal and then we repeated the FFR, and surprisingly FFR came out to be 0.68, which meant there is some proximal disease which we have missed, which is causing the real ischemia. So now when the angiogram was repeated in different views, we figured out that it was an ostial left mainstem lesion that was being missed. And that we caught because this FFR still came out to be significant despite of the stenting. Now, if you have two sequential lesions and you want to measure FFR across the distal lesion, which will be significant because it's accumulative of these two lesions, but if you pull your pressure sensor here in between the two lesions and you want to assess the FFR of this lesion, that will be falsely non-significant. Why? Because before this stenosis, the pressure will go up over here. When the pressure goes up because of the stenosis, distal stenosis, that means this PD value will go up because now the pressure sensor is here. So if the PD goes up, PD over PA, the FFR number will come out to be high. So there will be falsely negative representation of this proximal stenosis. So when you have two stenosis, so the best way to do it is do a pullback gradient and look at the waveform. Look at the step up created by this stenosis versus step up created by this stenosis, and then you can compare the two step ups and you can see which one is a more significant step up. But just to see the numbers between the two, FFR number here and FFR number here, may not be the true representation of the two sequential lesions. Now similarly, if you have a side branch lesion here, it is going to artificially raise the PDO at this value at this point. So the PD for this lesion will falsely go up and may give a false impression of non-significant FFR. So in any case, you can also remember it in a way that vascular bed will also decrease if the diagonal is occluded, and then the FFR may underestimate the significance of LAD lesion because then it may consider that this diagonal territory is no more there, so it's only this LAD territory that needs to be supplied by the stenosis here, and then in a way the vascular bed has decreased, so it may give a false impression of non-significant FFR for this proximal lesion. We have an issue with the jailed side branch lesions. So the measurement of jailed side branch lesions suggests that most of these lesions do not have functional significance, and I've just shown you an example of the ostial circumflex. Similarly, if you have a stent in the LAD and you have a jailed diagonal going across that stent, despite the morphologic appearance, it may not be functionally significant. So when in doubt, measure the FFR. Now this is a study by Koo and his colleagues, and what they've done is they've measured 97 ostial lesions in jailed side branches which were more than 2 millimeter, and no lesion with less than 75% stenosis had a significant FFR. So if the angiographic stenosis in the side branch, which is a jailed side branch, is less than 75% stenosis, that probably is a functionally non-significant stenosis, and you can leave it alone. And if in doubt, you can perform the FFR. FFR holds good for assessment of the left main stenosis as well. There is sufficient evidence behind it. So how do you do it? So the important thing is, if you have a FFR, if you have a left main stem lesion, especially the ostial one, you need to keep your guide catheter disengaged when you are going to do the equalization or normalization of your pressure sensor wire. So you can maybe keep the wire in the ascending aorta and do the normalization there and then take the wire back in. But whatever you do, your guide catheter should be disengaged, and when you do the measurement of the FFR distal in the LAD there, again at the time of FFR recording, your guide catheter should be kept disengaged. Then what's important, that it should not be intracoronary adenosine, it has to be IV adenosine infusion when you are doing the left main stem assessment. And then if you have a distal left main stenosis, it's important that you check the FFR in both LAD and then the FFR in the circumflex to get a true representation of the left main stem disease. So what could be the limitations if you have a proximal LAD stenosis in addition to the left main stem stenosis? What can happen? If you see this yellow pressure sensor here, if the pressure sensor is here, what we just discussed that because of this distal lesion, the PD value here is going to go up because the pressure is going to build up over here because of this distal stenosis. So this is going to give you a higher PD value. So higher PD over PA, that will give you a functionally non-significant FFR. So possible false negative FFR could be achieved with the pressure sensor at this point. Similarly, this is if you keep the pressure sensor here in the circumflex, then the very proximal LAD critical stenosis may do the same, that it's going to raise the PD, raise the pressure here across this whole region, and therefore it could give you a false negative FFR in the circumflex at this point if you take this as a significant side branch. And if you have these two lesions and you take a distal across this, you can get a cumulative FFR of both of these. So it's going to be difficult to say if this is significant or not, because this could be a false positive FFR as far as the left main disease is concerned. This is a cumulative FFR of these two lesions. So the way to differentiate would be to do a gradual pullback recording with IV adenosine Infion on, and then you see the bigger step up here or a step up gradient over here, and whichever is bigger gives you the impression of the actual significant lesion. Now we must remember that the coronary angiogram that we see here, epicardial vessels, is only 5% of the total coronary tree. The microcirculation that you see here comprises of the remaining 95% of the circulation. Look at this. Look at these tiny vessels that we don't see on the angiogram. So it's very important to use adenosine, because unless you use adenosine for this microcirculation, you will not be able to remove resistance truly from the equation. Now, for STEMI patients, FFR is not valid in the culprit vessel, and therefore the FFR should be done after 6 days of acute MI for the culprit vessel. Why is that so? Because after STEMI there is a variable degree of reversible microvascular stunning, and because of this the reliability of FFR in the first 5 days in the culprit vessel is not good enough.